Anyway, for blood gases, I like to ask a lot of questions too. So if I don't get an answer within like 3 seconds, I don't like awkward silence, so I'll just answer it myself. So if you're not for sure, it's okay. We can go through it. So let's start at the very beginning. We're going to go over the acid-base balance part first. I might get a little bit into the oxygenation, but I could probably talk about the PaO2 and oxygenation for probably 2 hours, and you guys don't want that because I really enjoy that part. So let's talk about normal values first. This is like the first thing you really have to know. So let's go normal values. So let's look at pH first. What's the normal values for pH? Awesome. 7.35 to 7.45. Great. Next one down the list for acid base, PaCO2. Normal values for that? 35 to 45. You know how it's easy? Because if you know this one, 35 to 45. Okay? So if you know your pH, then you got to have your CO2. Marker's not working great with this. You know what the units for this is? So PaCO2, we'll talk a little bit about this, but what does that stand for, PaCO2? Partial pressure of CO2 in the little a, which is the arterial system. Okay? There's also a big A, which we talk about with the oxygenation, but little a, so partial pressure of CO2 in the arterial system. So what might we measure pressure in? Yes, millimeters of mercury, right. Or as my RT instructor always used to mess with us, because she'd always put it in torr. It's the exact same thing, but it just sounds cool to do it in torr. So, but it's a pressure, millimeters of mercury. PaO2, normal value for that.
Greater than 80.
80 to 100. That's pretty simple, right? I'm going to put a little caveat with that 80 to 100. It's the same thing, millimeters of mercury. The caveat is a little star there. Star means on room air. Okay? Because it's going to change as soon as you add 1 liter of oxygen to them. It's going to change normal value of PaO2. Now, PaO2 is special because it is not part of the acid base, but it comes with every blood gas. It's looking directly at oxygenation. Okay. HCO3. Bicarb. What is our normal value for bicarb?
22, 26.
Awesome. 22 to 26. What is the units, or what are the units for these? All right. Millimoles per liter. All right. Not a big deal. It's not a pressure though, it's a volume that we're looking at. You're probably familiar with bicarb. So what we need to do with this, first we got to know our normal values. The second part is you got to know what side of a normal value causes acidosis or alkalosis, and that's all for today. So a lot of people say acidosis and basic. I say acidosis and alkalosis. It's very simple. So if your pH is below 7.35, is that acidosis or alkalosis?
Acidosis.
Okay, so acidosis. All right, greater than 7.45. Alkalosis. Okay, so more alkalonic. Now let's look at our CO2 next. Okay, less than 35 on our CaO2.
Alkaline.
Alkalonic, right. And greater than 45?
Acid.
Obviously the other one. Let's look at our bicarb. Below 22.
Acid.
Acid. Oh man, the marker's dying on me. Anybody have? Okay, awesome. So we have our, can you guys see that? All right. Okay. That's really, if you can memorize that, it's really downhill from here. But let's look at naming a blood gas. Okay. So we've got to name it. So first of all, let me give you a blood gas. All right, so you may have seen this before. If I'm working in the ICU as the respiratory therapist, you're the nurse, I might come up to you and give you the blood gas like this. I'll say, you have a 732, 52, 80, and 24. So, and we put slashes between them. It's kind of a shorthand way of writing them. This is always pH, CO2, PO2, and bicarb. So this is the way we always give blood gases. They always come in that order. So don't ever mix those up because that will really throw stuff way off. But 732, 52, 80, and 24. So we have some options for naming our blood gases. There's only really 3 spots here. And we name them backwards. So you start at the acidosis, alkalosis side and go the other direction. Okay, so from this side, in this space right here, it's either going to say acidosis or alkalosis. The middle space is going to be respiratory or metabolic, one of those 2 options. And then this space here, this is where it gets a little confusing, is fully compensated, partially compensated, or uncompensated. Okay, so we always kind of go backwards with it. Now, fully compensated, another double star here. pH is normal. Okay, so you have to have a normal pH to be fully compensated. So that kind of takes that one out in a lot of cases, but I'll give you some examples of it. So let's go through this blood gas and just look at each one of these, compare it to the normal values, and see what it is. Call it acidosis or alkalosis. So, acid, right, 52, normal, and normal. Whatever your pH says, right here, acidosis, it goes right here, easy enough. Now we're going backwards, so we got to look at respiratory or metabolic. The respiratory system directly controls, the best word for this is ventilation. So we have 2 different things. We have ventilation and we have oxygenation. 2 very different things. You can ventilate and not oxygenate, or sometimes you can oxygenate and not ventilate very well, you know. But those are 2 separate areas. Ventilation, every time you hear the term ventilation, just think of CO2. CO2 each time. Why do we put somebody on a ventilator? We want to get rid of CO2 in most cases. Now, if their oxygen is really low, we can give them a lot of oxygen on there, but ventilation and CO2. So, anything that has a problem with the CO2 is a respiratory issue, okay? Anything that has a problem with the bicarb is a metabolic issue. So in this case, you find out which one, the CO2 or the bicarb, matches the pH. So in this case, it's pretty easy. Our pH is acidotic. This one's acidotic, this one's normal. We're going to say this one matches, so this is respiratory. Abbreviate it there. So respiratory acidosis. Now we get the compensation. Okay? Compensation is, are we getting help from the other side of the acid-base balance? So things you got to know about how this works. CO2 and the respiratory system works very, very quickly. If you stop breathing right now, your CO2 is going to slowly start to climb as you're not ventilating. It's going to climb very quickly. It can cause your pH to drop very quickly. What's your body's reaction to that in this acid-base balance? Well, as your CO2 starts to rise, it tries to offset it with the bicarb. And in this case, bicarb, we'll talk about it in a little bit, but what it's going to do, it's going to get rid from your renal system, from your kidneys, it's going to get rid of more of your hydrogen ions, and then that's going to keep more bicarb around. And we'll talk about how that works. So then this thing will try to slowly creep up, but here's the deal. Bicarb moves very slow, okay? Very slow over time. Hours up to days that takes it to move, okay? There's one case that it moves a couple cases it moves very quickly. Mainly if somebody codes. Somebody's heart stops, they stop breathing, bicarb falls, CO2 rises really fast, and that's a bad effect, and I'll show you a blood gas for that in a second. But in this case, we know it's respiratory acidosis. Are we getting help from the bicarb side or from the kidney side? Negative. We are not. So we are not getting any kind of compensation from that side. So it's an uncompensated respiratory acidosis.
So how do you know it's not helping or helping?
I'll show you in a second. Because this dude right here is sitting on normal. Okay? Let me show you in the next one. This will make sense. So he's at, as far as I know, he hasn't gone anywhere. Okay, uncompensated respiratory acidosis. Also could be called acute respiratory acidosis. I'm going to start using those type of words, medical terms. Because this happened really fast. They didn't slowly get up to 52 because if they did, their bicarb would have came up to help. Okay, let's go through this one. Same way, don't jump the gun, go through it methodically. Start by naming them at the top. Acid, acid, normal, basic, or alkalotic. Okay, what does the pH say? Acidosis. Which one matches your pH? Respiratory side. So if you don't get that, I mean, that it hangs people up sometimes. It's okay, but these two match. So we're going to call this respiratory. And now we're coming to compensation. So is this guy? Is he trying to help?
Yes.
Yes, he is, because it's going into the alkalonic side, trying to offset this. These two guys right here will offset each other to make this normal. The goal of the body is 7.40, but we have this little range where we kind of fluctuate a little bit and all our functions are normal. So, are we trying to help? Yes. Is it enough help? No. That's where we go to partially compensating. So, partially compensated respiratory acidosis. Tell me about this patient. What might you see with this patient? Just give me respirations. Could be depressed respirations. Yep. Could be oversedated, depressed respirations. All kind of goes together. Yeah, it definitely could be. Yeah, so we're hypoventilating right here. I'm saying that because this CO2's up. But this didn't just happen like 5 minutes ago. This could be going on a whole night long. COPD, yes, we'll talk about that obstructive disorder in a second. That will come, it definitely could be. It could be an early patient with early emphysema or some kind of obstructive disorder. So why did you say that? We'll talk about that shortly. But so this is going up. This is not like, this didn't just get to 72. It didn't go from 40 to 72 like in the last 5 minutes. It's been over a little bit of time. How do I know? Because this guy is starting to try to compensate. Is he compensating enough? No. Do we need to do something? Yes. Because the body's not doing what it's supposed to be doing right now. It's slowly working, but I'm not going to let somebody sit on a 725 and a high CO2 for another day and say, well, look, kitty's catching. What are we going to do? What might you do to help ventilate this patient more?
Put them on a ventilator, maybe?
You can put them on a ventilator, you could. Yeah, you look at other comorbidities, but you definitely could. What's something that we have all over the hospital that you see running all the time? Oxygen, yes, that's right. But oxygen's for this side, and it wouldn't do squat if we had oxygen right now. And Entitled CO2 would measure this, but it's not going to treat it.
Spirometry.
Instead of spirometry, could, but it's really, really slow. Breathing treatment, not really. I mean, you could open them up a little more, but in this case, I mean, they're acidotic. I mean, this you feel bad at that. You're not feeling good.
BiPAP.
BiPAP, bingo. Great. So non-invasive. BiPAP is that is the kind of the brand name. Do you guys know much about this? Let me hit that a little bit because it's huge. I mean, even nurses that we're hiring in, we go over BiPAP, CPAP a lot. So I'll hit that after I do the blood gas stuff. The best way to do it is NIPPV. This is a brand name, right? So NIPPV is non-invasive positive pressure ventilation. So you're getting positive pressure, but it's not invasive. You did the mask. Okay. So that's a great thought. So we're going to put this mask on them, and it's going to deliver extra pressure and help to augment their own tidal volume. So they take a breath in, their tidal volume is the amount of air they take in each time. It's going to augment it, help get more air in, therefore more air out, and you get rid of CO2 when you ventilate or the air comes out. So I'm much more worried how much air is coming out than how much I'm putting in, okay? So put them on a BiPAP. Great idea. So put them on a BiPAP, try to get their CO2 down. We usually wait an hour or so and draw in their blood gas. So, awesome.
I'm still confused on, I'm sorry, on the partially in the compensated part.
Okay,
Like,
let me do another one.
okay,
Let me do another one. I'll do a more,
like when you say it's not compensated enough, so it's partial, how do you know?
okay, so it's helping, right? But it's not fully compensated until your pH is normal.
Okay.
So I'll show you one of those in a second. Let me show you one now. I just told your hand. Oh, no, I'm not gonna show you that yet. I gotta do another one first. Let me do, okay. Okay, 7, 2, 3, 23, 110, and 15. Let's go through it methodically again, okay? Acid, alk, normal or a little bit high, matters what kind of FiO2 we're on, or kind of oxygen we're on. And this is acid. Okay, so this says acid, we put it over here, acidosis. Who do we blame it on? Which one matches? Metabolic. Does everybody get that? Because this is acid, this is acid. So, is the respiratory system doing what it's supposed to do? It's trying, right? It's going the right direction. It's out of normal range. That's what we want to see, really. That's kind of the key. It's out of normal range. If this was 35, I would say uncompensated because we're not getting help. But since this is 23 and it's going down at the alcoholic side, I'm going to say this is partially compensated. What would make it fully compensated? Does everybody get that part first? Yes, your pH is normal. So what would make this pH normal?
7.4.
Yeah, if it was, at least it needs to get 7.35 because they're normal. What would have to change for it to get to there from this point? The CO2 could, or which way would it have to go? Yeah, so the CO2 could go down, and that would bring this up. This alkalosis would offset this acidosis and bring this to normal range. That's one option. What's the other option? Yeah, so, no, this right here. This could become more basic. So it could go closer up, come closer to a normal level, a 22 to 26, and then bring your pH to a close to normal level. So if you can understand that part, that's really like the key to all of it. So these two fluctuating this way. So partially compensated metabolic acidosis. Now, describe to me what this patient might look like when you see them from the door, when you walk in. Anything you could probably notice when you walk in the patient's, let's say they call rapid response, and you come in with an ICU nurse, and you walk in, because they've usually been doing it a couple minutes, you walk in with an ICU nurse, the patient's sitting there, and they said before, patient's in a partially compensated metabolic acidosis. You walk in the room, what should you notice from the door?
Hyperventilating.
Awesome. Perfect. They're hyperventilating. So, how do you hyperventilate? Can anybody show me?
Anxiety.
What's that?
Or anemia.
Yes. So your respiratory rate is usually higher than normal. What's normal respiratory rate? 12 to 20, right? Or what you'll really notice is not just respiratory rate, but maybe their tidal volume or the volume they're taking is more than normal. So you can see somebody with a 23 sitting in the bed, and you walk in, and you just notice when you walk in. So the first thing I look at, and it's not because I'm a weirdo, but when somebody's having respiratory issues, I look at chest excursion. You can see how chest excursion changes a little bit. A lot of times their rate may not change, but the volume they're taking in does change. So why is that volume being larger? It's because our brainstem's telling them to do it. That's all autonomic. Their brainstem's telling them to do it. So you walk in, yeah, they might be breathing 20, which the PCT has been documenting 20 or 16, 18, 20, 20, 20 for respiratory rate over time. But then you walk in and you just notice more chest excursion. That's all autonomic. They're doing that for a reason. Their body is trying to use the CO2 to get this pH to normal. So yeah, they could be hyperventilating. They could be having a larger chest, greater chest excursion. The AP diameter getting larger each time they take a breath. We have a lot of reserve to do that. I don't know if you guys know that. We have a lot of reserve to do that. And our brainstem, receptors in our brainstem tell our diaphragm to change our breath, every breath, to keep this 7.40. So that's really the amazing part about all of this. But they'll be doing it and they won't even notice it. What might cause this metabolic acidosis?
Anxiety.
We'll talk about anxiety. Not really, but kind of. Diarrhea, why diarrhea? That's like this. Okay, so the cool thing is, wait for somebody to say it. It's like the number one nurse answer there is. You guys are real nurses now. So it's always vomiting or diarrhea every time. So you might have a focus, I don't know. So how would diarrhea cause it? Yes, so this is, you can get this, so you lose base from your butt, okay, you can think of it that way. So you're gonna lose base from your butt, all right. So, yeah, you have a loss of base because you have mass quantities of, this is real deal diarrhea, all right, this is not just your normal run-of-the-mill. So this is bad diarrhea, yes, you could. When are you gonna know when your patient's diarrhea is actually affecting their metabolic system? What are you going to watch for from a nursing perspective? Watch their rate. Man, you pick up on that early, you know right off the bat that they're getting more acidotic before you even draw a blood gas. So these are all different signs we can look at before we even get any kind of diagnostic test. So you have somebody that comes into the ER and they've had really bad diarrhea and dehydration for a couple days, and you'll notice. It's really cool because you might pick up on this now. Just doctor respiratory, it's like 22, 24. I bet they're in a metabolic acidosis. So let's draw a blood gas and find out. Fix the diarrhea issue, you can fix it, and give them more fluids and stuff. But yeah, diarrhea is one. Okay, that's a small one. We'll put it down here. There's a couple other big ones that cause metabolic acidosis. It would have to be pretty bad. Tums. You guys are like that. That's a good one. You can. Why? Why Tums? Tums OD. That's the
It's
thing.
made of bicarb, basically.
It's made of bicarb, and the cool thing is that your body's acidic properties is usually manipulated by your stomach. That's your mass of acid in there. So you OD on Tums because they taste good or whatever's going on. Yeah, you can put yourself in a little bit of a metabolic acidosis. A lot of times you'll compensate and it won't be a big deal. Thinking about some other big hospital diagnoses you might see. Renal failure is a good one. That's one of the big ones. So there's three big ones. That's one of the big ones. Renal failure. Why renal failure?
Because your kidneys aren't getting rid of that, getting rid of the stuff that...
Hydrogen, really. Think about it as hydrogen. You're not getting rid of hydrogen ions. Renal failure is huge. DKA is number 2 of the 3 biggies. DKA stands for what?
Diabetic ketoacidosis.
Diabetic ketoacidosis. Bonus point, what is the breathing pattern you see with DKA? What'd you say? Kussmaul's. Why Kussmaul's? Trying to get rid of it. So why does a person DKA have Kussmaul's? What the 2 descriptive words for Kussmaul's, not descriptive, but the best description for it is fast rate and large volumes. Why are they doing that?
Oh, the ketones in the breath.
It's ketones on their breath, but it's not the reason. It's because they're acidotic and their body's compensating. Their brain's saying, go, 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 go to the diaphragm. So if you tell them, this is one of the big kind of things that when I used to work ER, we have a lot of people coming with anxiety. So What do you think the normal anxiety age is? It kind of goes
20.
all over. Teenagers, 20-year-olds, 30-year-olds, whatever. I mean, all the way up. But what about these people that are first-time type 1 diabetics coming into the ER? How do you think they're acting? Anxious. Is anybody type 1? All right, so anxious. For one, you do a finger stick glucose on them, and on the machine it just says high. That's bad. It's like above 550, right, in most cases. So, newly diagnosed, coming to the ER, they look just like anxiety initially, until we get a glucose, and we're like, oh shoot, we can fix this. You know, not with Ativan or something like that. We can fix it with, you know, insulin, and they might be on insulin the rest of their life. But the number one thing that always kind of got me is that you see a, let's just be stereotypical, a 13-year-old girl come in, right? And she's breathing fast like that, and the parents are like, I don't know what's going on with her. In the back of our jaded minds, we're thinking, oh gosh, school drama, freaking out, having nervous breakdown, something like that, right? So we try to treat them with something, you know, some kind of Ativan, Xanax, something like that. So the thing you got to watch out for, though, you know, this is one thing that they used to do, and I'm not a big fan of it, and I'll tell you why. Is put a non-breather on somebody when they're hyperventilating, just acutely hyperventilating, put a non-breather, and they wouldn't plug it into oxygen. Like what your grandma told you, breathe into a bag. Why did she say breathe into a bag? Because you would blow out your CO2, and then you take it back in, you'd rebreathe your CO2. All right? So, what would happen if I took this patient, let's say this patient's in DKA, and they look like they're anxiety, and I tell them to breathe into a bag? Yes. You're exactly right. It's going to be totally counterproductive. It can really cause them to crash. Because start breathing into a bag, what's going to happen to this number? Going up. As this one goes up, what happens? This dude here falls like a rock. Because this is no longer compensating, no longer allowing the body to do what it's supposed to do and compensate, and your pH starts to drop really fast. So, a little case in point, if you have a situation like this, you want to make sure that there's not an underlying cause, and DKA is a definite underlying cause. You don't want to stress anybody out any more than they already are, because usually, if they're early type 1 and they come in, they've probably been breathing fast for maybe a day. And we see this with COPD patients a lot too. You breathe like this for a day, you know, what happens after so long of breathing like that? You can pass out, but they don't in this case. Most of us, when we breathe fast like that, we pass out because our body goes into shutdown mode, says, I know how to fix this, boom, and then puts you back in normal respiratory rate. So what happens is if they're breathing like that for a long period of time, and let's say their oxygen level falls a little bit, what's going to start to wear out? The diaphragm or their muscles. We see the COPD patients a lot. They're breathing fast like this, they don't have any help at all, their muscles start to wear out. What happens when your muscles wear out or you go into anaerobic respiration? Your muscles release what? Lactic acid, right? We've all had sore muscles before. Lactic acid's released, guess what happens? This number starts to drop even farther. All right, so this is our DKA patient breathing really fast, starts to wear out. When this falls, the pH is going to fall even more. So that was a bad patient situation. All those things happening. But so we've got two of them. We've got DKA, we've got renal failure, we've got some other stuff. What's the last one? A little more difficult. It has to do with release of lactic acid. It might be a patient that's from, let's say, from the nursing home that has a UTI. Sepsis. Bingo. Sepsis. So your septic patients might have metabolic acidosis from the lactic acid. So you have your patient that you're seeing the nursing home or anywhere else, interdwelling catheter. You go and you see their respiratory rate, they have fever. Respiratory rate's been bumping up every time you went and assessed them. Wow, are they compensating for something? Because, you know, they don't seem anxious, nothing else seems to be causing them. They compensate for something. Maybe they're compensating because the bicarbs aren't falling and becoming acidotic. So in this case, we can do a blood gas, or we can just start treating. Now, renal failure, we can treat it. We can do continual renal replacement therapy, do dialysis, all kinds of different stuff like that. DKA, that's one of the easier ones to treat. Sepsis is more difficult. It's going to take a while. So if they're taxed a lot, we may really consider putting them on a ventilator. And I've seen a DKA patient go on a ventilator before, just because they were working so hard. And when we put them on a ventilator, this is the cool thing about it. When I put them on a vent, I now have total control over their CO2. I can make it go high or low or wherever I want and not put any stress on the body, because I can change the volumes and rates on my ventilator while we try to fix this issue over here. So that's what the intubation part and the ventilator part kind of is the trump card, where you can come in and take over this and kind of get their acid-base balance back into whack. Awesome. Okay. A deep explanation of that. Let's do some more interesting ones. I have some patients, many, I know at least 5 in the community that have blood gases like this we've seen here. Let's go through it. What is this? Normal, right? Acid. This is low. And what's this? Alkalotic. So what are we going to do? I mean, because when I bring this blood gas to you, let's say I bring it to Caitlin and I hand her the blood gas and I said, well, or I call you from the blood gas room and I say, Caitlin, we have a panic 105 CO2 and a panic value of 49 on the bicarb. And then I bring the blood gas to you and I go, here you go. And I walk away. You're like, what? What do you want me to do? You know, I need to call a physician with these numbers. But the great thing about it is you got to know, what is the physician going to say? You got to, that's kind of like, you know, in RT school, we don't get this until like a year to 2 years after you graduate, when you actually can make so much sense of it before you even ask the question, you know the answer. And that's what medicine's really all about. That's when you know that you're really pumping on all cylinders. Before you ask the question, you already have about 3 answers that they could give you that are all good fixes. That's when we become great patient advocates. So let's look at this. Acid, alk, and normal. Well, we got to call it something, right? Because something's not right with it. So let's look at this. Let's look at the center of it, 7.40. What side are we on? Acid. So I'm going to do this. Who do we blame it on? And what do we call this? That was really like many people at once. Fully compensated is what it is. Because remember, fully compensated says you have a normal pH. So, what might this patient look like? Maybe fine. I mean, it might be fine. You said hypoventilated? You are correct when you say that. But, is this acute hypoventilation? Heck no. They've been doing it. This has taken many years of Marlboro Reds to get to this point. I don't know if it's
I don't smoke longer, this will be both, thank you.
well, maybe menthols. Yeah, so maybe menthols. Anyway, this doesn't happen overnight because we know this bicarb's up. pH is normal. The body is doing what it's supposed to do. They're offsetting each other, and we have a normal pH. So this is one of our patients that could have COPD. Now, let me just talk just a real quick thing about COPD. COPD stands for what? Okay, there are 5 diseases that fall in COPD. So when you say COPD, it's really generic. There's 5 diseases that fall into it. Does anybody know what they are? Okay. There was 2 of them. I just heard. Hold on a second. There is a good acronym for it that we memorized in school. CBABE. It doesn't make much sense, but whatever. CBABE. These are the 5. And what is the key with this? It's the O, obstruction. And what does obstruction mean? obstruction to flow, and it's expiratory flow. Remember, if you can't get your air out, then you can't get your CO2 down. You've got to get air out. So obstruction. So somebody said chronic bronchitis. No, that's emphysema.
Asthma.
Asthma is on here, but so asthma, the cool thing about asthma is it's really funky. It's obstructive and restrictive, which means you have smaller airways because of the inflammation, but it can be both. CHF, no. That's a good one though. CHF, your issue, so alveoli, all right, so a lot of times with obstructive issues, your issue's up here. CHF, you got water down here, right? So you don't have obstruction of flow coming out. Emphysema, these airways are weak, so you take air in and it doesn't come out very well. Chronic bronchitis, you got like mucus in here. What is my, please, think about mucus. Excessive mucus production is one of these other ones.
Cerebral palsy.
No, but another two-letter acronym.
Cystic fibrosis.
There you go. Yes. CF, not
That's
CP.
close.
Well, you got C right.
I was on there.
That's all right. So, cystic fibrosis, mass quines of mucus, obstruction of flow. That's a type of COPD. Somebody has cystic fibrosis, this is pretty high. This is usually an emphysema type CO2, but they might have a normally elevated CO2. This one's difficult. Bronchiectasis. You've heard of bronchiectasis before. Bronchiectasis is really, the best way to describe it is sloughing of the airways. So it's really bad. Doesn't sound nice. But that's another mucus issue. So those are all obstructive issues. And obstructive issues, obstruction of flow, therefore not very good ventilation, therefore we could see a high CO2 for obstructive issues. So when you say COPD, you're thinking in the back of your head, when I say COPD, and you'll ask patients, do you have COPD? Yeah, I have COPD. They don't have a clue what type they have. They just say I have obstructive disorder. Unfortunately, physicians use the same stuff. They don't use it correctly. So I always like to say what is actually the cause, because they're treated a lot different. So this is somebody with probably obstructive disorder, but they're normal. They can be breathing normal right now. Okay. So what would happen if we send them home? They have a pneumonia. We send them home. They come back in a couple days. Now they have this blood gas. Changes the game. 725, 115, 60, and 50. Acid, low, and alpha. Now they went from a fully compensated respiratory acidosis to what? Awesome. Partially compensated. Yep. Partially because this guy is out of normal range and he's trying to help, but he hasn't helped enough.
So at what point do you feel like it's, I'm still struggling
That's okay.
with compensated.
No, it's okay. When I say
No matter what, is it low or high, it's compensating?
if it's out of normal range,
Either side?
that's the next one. It's got to go, so if this guy's acidotic, the goal is 740, this guy has to go into the alkalinic side to be helping. You get that? He's trying to get, you got all this acid over here, so he's trying to get more alkalinic to even them out, to make your 7.40.
Then the opposite.
That's the opposite.
That's the wrong.
Okay. Okay.
Yeah, the cancel should out. So let's look at the next one. So that's bad for that one, but let's look at this. So Seven, 1, 5, 55, 70, and 18. Go through it each time. Acid, low, acid. So we know this says pH, this is acidosis. In this case, we can't really blame it on anybody, right? Because both of them are acidotic. So we don't know which one actually came first. We really don't. unless we can know the exact cause. So we call this combined or mixed.
They taught us yesterday that it would be that involved, because you're looking at, like, pH is low, or bicarb is low, pH is low. Well, no, he's not, okay, never mind.
Yeah.
I think we were told whichever was further away from normal would be the one we would go with.
They don't. You guys don't do mixed?
No.
Maybe later.
Okay.
So this would be a mixed one?
Yes. I call this mixed. What would you guys call this?
Respiratory or
Because why?
because that one's further away from normal.
It's 10 away from normal, and that one's
Only
4,
four.
but it's a different scale. Okay. I get what you're saying. No big deal. Okay, so Jimmy's gonna call it mixed acidosis, and you guys can just call it what you like. So, okay, so we know we'll just call it a respiratory and metabolic acidosis. Is there any compensation with this? No, because everything's going the opposite direction, right? I mean, it's opposite. Respiratory opposite, that stuff. But anyway, it's uncompensated. So we just call it mixed acidosis. How do we treat it? This is dire straits, and this is the reason why. Because when this goes acid and this goes acid, the pH falls really, really fast. And this is, the body is failing right now. It's not doing what it's supposed to do.
So would you vent and give bicarb?
Number one, you're going to ventilate them.
Yeah.
All right, we can talk about the bicarb thing next, but number one, you're going to ventilate them. Yeah, so I'm going to take control of this. Put it in the tracheal tube and put it on a vent. Now take control of this. Now figure out what's causing this. I can throw some bicarb in, but I'll show you kind of what that does here in a second. But so put them on a vent right off the bat and fix them there. And then look at some causes for this. We can bring this back closer to normal, right? Now we don't want to run somebody at a rate of 24 on a vent for a long period of time. We want to get their blood back to normal pH and then fix this issue. Find out, what is it? Is it renal failure? Is it dialysis? Is it sepsis? Are they in DK? We need to figure that stuff out. So we take over this first because that's really easiest to take control of. Any questions about that at all? Is this like making it worse? Hopefully good. Okay, good. All right, so let me do this one here because I was asked about it. Seven, 5, 2, 22, 110, 23. Let me give you a little caveat behind this one. We have blood gases like this all the time. All the time. Usually, I get a page, Jimmy needs to go down to pre and post, actually it's to the pre-op lab area. The patient's going to have an open heart surgery tomorrow, and we need to draw a pre-op blood gas on them because we want to see really what their levels are before they go on a ventilator tomorrow for anesthesia. So, see this blood gas a lot down there. I draw the blood gas, and I'll set it in their chart, and then maybe even give it to the anesthesiologist. They look at it and go, whatever, no big deal. Wonder why. So let's look at it real quick and see why they said that. So, alk, normal or high, normal. Right? Alkalosis, that's what the pH says. Uncompensated respiratory alkalosis. Describe this patient to me. Right? Acute hyperventilation syndrome. Now, not always are they hyperventilating, but they can be taking a couple extra. You do a couple extra large side breaths, and you can get your CO2 down. It doesn't take a lot. Your body will compensate and bring it back normal if it can, but has anybody ever had a blood gas before? You know we have to access the arterial system. How was your blood gas?
It hurt.
Yes, it does. It's a very good description. It does hurt. Yes, it is deep. We don't go along with the skin. We go to 45-degree angle. So if Caitlin was getting a blood gas, my hands are really dirty from that thing. So I'm gonna turn like this, I'm gonna feel right here, and I go in at an angle like this. Okay? It's 100% by feel, and it can be painful. The reason it's painful is because we were made that way. We're just a mess with arteries, right? So there's nerve endings down around those. So what do you think when you tell somebody, especially somebody's had a blood gas before, and unfortunately, it's usually a man, because we don't tolerate stuff as well, is you start to go and you tell them you're doing blood gas, and they start freaking out right off the bat, acute hyperventilation. Am I concerned about this for their open heart surgery tomorrow? No, because the anesthesiologist is going to put an arc line in after they're already in surgery, so they'll never feel that. So, uncompensated respiratory alkalosis. Nothing of major concern with this. Now, if this was changing for some reason, then we got to think, is there something for concern? So,
It's uncompensated because it's normal, the bicarb's normal.
bicarb is normal. Exactly right. Okay, this is a question for you. So, what would make it partially compensated? What would the bicarb have to do?
Yeah, what?
No, it's okay. It's okay.
Or
It would have to go.
acidosis.
Yep, it had to be 21.
Okay.
You get that because it's trying to help out by going more acidotic, and it can do that because what the kidney does is it stops accepting hydrogen atoms and leaves more hydrogen atoms, and your bicarb drops because of that. So if this went down to 21 and everything else remained the same, it would now be a partially compensated respiratory acidosis.
So it's
Sorry, respiratory alkalosis. Very sorry.
so it's going to be opposite,
Yes.
right? I mean, so even if it, like, say that was acidotic, and then that would go alkalotic,
Yeah.
then it would be still partially compensated.
Yes.
Okay.
Until your pH got to normal level. Then it's fully. So you should never write fully compensated unless your pH is a normal level.
Okay.
Yep. So,
And
yes.
it's uncompensated because it's normal.
Yes, because it's not help. As far as we know, this guy's just sitting there not doing anything, so he's not helping. It's uncompensated. Okay, so let's talk real quick about two different things. Oh, three different things, but real quick about them. Just because this is bonus. This is bonus stuff for you. And then we'll come back and do some blood gases. So PaO2. We haven't been talking much about that. I've just been throwing out some numbers for you on room air. So that's normal on room air. Well, where in the heck does that come from? Well, okay, so let's see, is there anybody really into science? Let's take a box of room air here, okay? Room air. What percentage of that box of room air is oxygen? What is it? You're close. We just generally call it 21. It's actually 20.9. 21% is oxygen. What is this vast majority right here? Like 78%. Nitrogen, awesome. Back in the Al Gore days when he was actually, somewhat of a person, the people used to always say CO2. That's not right. No, so less than 1% is CO2, argon, all this other stuff. So this is the air we breathe. Okay? This is air we breathe. We take the air in, goes through all of our conductive airways down to our big old fat alveoli and across to our blood. So by the time we take this room air in, it goes all the way down to here and goes across. Usually we have about 100. I'm converting this over to pressure. This 21% converts over to pressure. About 100 here. So we say 100 to 80 is normal over here on room air, right? So this air inside of here is called our P big AO2, but we won't talk about that today because there's another equation for that. But what it is just how much is available in there. We call it available oxygen. So there's an equation we can put this in, and the RTs can do this, but every time I give a PaO2 value, I want to know how much oxygen they're on. So if I put somebody on 2 liters of oxygen, I change their percentage now from 21 to what? That's why you say it, 24. Does everybody know that? For every liter you go up, it goes up by approximately 4%. and we start at 20 to make math easy. So on a regular nasal cannula, it goes with 6 liters. So if we're gonna do 2 liters, we're gonna have 24% up here now. And just generically, it's gonna convert to maybe about 124-ish, just an estimate, in the alveoli. Well, if we have normally functioning alveoli, what should we have over here? 124, right? 124 or 20 less than that should be normal. Just on 2 liters, normal alveoli. Well, let's put somebody on a non-rebreather, which we see a lot of that. So you put somebody on a non-rebreather. How much oxygen are you giving somebody on a non-rebreather? 15 liters usually, that's 100%. So 100%. So if I put any one of you guys at normal lungs on 100%, and I wait 10 minutes or so, I draw blood gas, you probably have about a 550 to 600 PaO2 in here. A lot of extra oxygen, which goes straight over here, 550 to 600-ish for normal functioning lungs. This is where it comes in. If I say I put you on a non-rebreather, and I draw a blood gas on you, and your blood gas comes up like this, pH 7.38, we have a CO2 of 40, a PO2 of 205, and a bicarb of 24. Everybody looks at that 205 and they say, he's oxygenating great. Is he? Heck no. He's got, what we're saying, we got a non-rebreather on him, and we only have 205 coming over to here. That's not good. So what could cause that? Obstruction. Okay, there's one. There's tons of things. Fluid buildup. Yeah, you got the fluid in here. Yeah, that's big time. Yeah. What else did you say? Yeah, white lung. Pulmonary fibrosis? Exactly right. So pulmonary fibrosis is really bad. It affects this area right here. There's 9 layers of tissue here in this membrane. Pulmonary fibrosis is really bad. Any kind of pneumonia, anything can cause it, really. So this is a little bonus that I'll give you. And I've yet to hear a nursing student say this to me, but I'm waiting for the day. It's going to be a good one. Because anything that causes an issue with that, we term it as a VQ mismatch. All right, so let me describe this real quick. And this is like the super smart Trump answer you can give. Walk into a room, sound really smart. I'll show you how. So VQ mismatch, ventilation and perfusion. So if we have a stick person here, which I cannot draw people, and they have square lungs. So what we do is you have these 2 areas. You have this area, it's like zones. You ventilate really well in the upper parts of your lungs, and you perfuse really well in the bottom part of your lungs. Because perfusion is more the blood flow, and it's due to gravity. And we ventilate in the higher because of gravity. So this area in the middle is where we have really good VQ matching. We have ventilation coming in through our alveoli, and then we have good perfusion from our bloodstream. I have about killed your markers, by the way. Yeah. Your instructor always used to know this. So you have really good ventilation perfusion. That's middle areas. So VQ mismatching just means you're not ventilating perfusing. It can be any type of disease process. So next time you want to sound really smart and getting a report on your patient, you guys are doing clumsy perturbation, walk in. Well, they only sat in like 88 on 2 liters. All you need to say is having some kind of VQ mismatch issue or something. If you say that, you're always right. Now, you don't have to define it any farther than that because people are going to be wowed by you like, what did he just say? So I'm yet to hear anybody come in and say, there's a VQ mismatch issue over here. I would love to hear somebody say that to me sometime. It'd be like really exciting. It's like, seriously, it's like if you're in Sunday school and you're like asleep and somebody calls on you, if you usually say Jesus or prayer, you're usually good. So VQ mismatching is kind of the same. It can all loop back and you can like make it work because it can cause any issue. So VQ mismatch is an issue with that stuff. But the whole thing I was talking about with looking at the PaO2 with the FiO2, that's called PF ratio. And once you do ICU clinicals, you'll do this on every ventilator every day. Because you'll look at this PF ratio, and I won't go into that today, but that's a lot. That's the oxygenation point. So every time you get one of these numbers, It means nothing unless I know how much oxygen they're on, okay? And it's on every blood gas. We say how much oxygen is on every blood gas. All right, so next one, BiPAP. That's the one. Okay, so CPAP. This is bonus. I usually don't do this with you guys, this stuff, because this is such a hot topic issue right now. So CPAP is an acronym for what?
Continuous positive airway pressure.
Continuous positive airway pressure. Okay, one pressure. One. Okay. Versus BiPAP. Bi, two positive airway pressures. Okay. So it's two pressures. So these are different things. What's the main use for CPAP?
Sleep
Sleep apnea is right, but there's a better description even. There's two types of sleep. There's actually three types of sleep apnea. Obstructive sleep apnea, so OSA, and there is something called central sleep apnea. This is all bad. Does anybody have central sleep apnea? Okay, well, I'll tell you about that. What happens, so obstructive sleep apnea first is usually your airways are large, not always, but they just, when you go to sleep, they become floppy and they close off. So what do? Has anybody ever had a sleep study? Okay, you'll probably have one some in your life. Almost everybody's getting them. They're really cool right now. So what they do with a sleep study is they hook you up to an EEG, but they put a little thing that's flow monitor under your nose and something on your chest for chest movement, and then they say, go to sleep, I'm going to watch you snore. So what they do is they're looking at the person. It's really bad drawing again. Looking at their chest and their nose. And so somebody starts snoring. Everybody probably slips somebody that snores. You hear them snoring. Okay, there's some obstruction there. Has anybody ever heard anybody stop breathing? All right, so what happens when they stop breathing? Oh my gosh, they wake up, right? That person needs sleep study. So what happens is they're obstructing. As long as they're snoring, I always say they're moving air. It's when they stop breathing. So what happens is their airways like this, the tissue kind of closes it off, and they'll go, and it'll be quiet, and then what happens is their brain just woke them up, and they woke back up again. So these are people that are not sleeping at night. It's detrimental to every part, every organ of their body. So what do? They measure the flow at their nose and the movement of their chest. Obstructive sleep apnea, their chest is still moving, trying to breathe, but they have no flow coming in, so we have obstruction. Put it on a CPAP, and it splints the airway open. We keep that pressure going in, and it splints it all night long so they don't close off and they sleep all night long. Central sleep apnea, it's a different story because they're snoring, and all of a sudden flow stops and the chest stops moving. What the heck? Central, look, talking about the brainstem. So some people, their brainstem just shuts off and they stop breathing at night. And then all of a sudden, they come back. So when they're looking at those two different things, obstructive sleep apnea is fixed with CPAP, but central is with BiPAP. And I'll show you that in just a second because BiPAP is not just a one pressure, but it's two. And I think the best way to show it is by just a waveform drawing of like pressure over time. So it'll look like this. There's one called an IPAP, and there's one called NIPPV. Now don't get hung up on this stuff. Expiratory and inspiratory. So let's say they're going along here, and then what this will do, it'll fluctuate the pressure up at a specific rate. So all this area here is splitting the airways. This area here is ventilating the patient. So if they have central sleep apnea, we want this thing to kick in and give them a breath every once in a while they're sleeping. Or a patient with emphysema or any problem like that, because one of the biggest things you'll hear from emphysema patients is, I wake up every morning and I feel really bad until about noon, and I start to feel better, and I go take a nap, and I wake up again and I feel really bad again. What's happening while they're sleeping is they hypoventilate and their CO2 rises and they wake up acidotic. They don't catch up till about noon until they get something to eat. They take another nap. What they need is a BiPAP type unit at night, which helps to ventilate them at night. So two pressures, one pressure. This does oxygenation and ventilation, or O2 and CO2, and CPAP just does oxygenation and splints the airways. So that's the main difference between those two things. It's really generic, but that's it. We almost all our machines will do either one, and I have one class that I used to do where I bring a CPAP in and let somebody try it on. Because it's kind of cool to actually, we had to do it in RT school, we had to wear it, and then it gives you a lot of empathy for your patients when you have to put it on and they're not used to it. Now patients that have emphysema and they've been on BiPAP before, I put them on a patient before and they've actually like fell asleep because they've been working to breathe so long and now they have this extra. This helps to augment their own tidal volume and then they feel really good. They're not working as hard anymore, so that helps them a lot. All right, so that's generic BiPAP, CPAP. Or non-invasive positive pressure ventilation, I guess. That's the purpose for it. And you guys are almost done. Well, there's one last thing I was going to go over. Must not have been that important. So before we go, I want 3 volunteers, and I'm going to give 3 blood gases to you, and I want you to interpret them at the board.
Who wants to go?